living with OPMD, Oculopharyngeal Muscular Dystrophy. In the next while, we're going to discuss this very important disease that is more and more prevalent, at least more and more diagnosed in the world. Just just one disclaimer is that I'm a PI in a trial, a trialose trial led by BioBlast in Montreal and elsewhere in America soon. So what we're going to discuss in this video is give you some background, an overview of OPMD, which I'll do, and then I'll talk to you about the medical treatment and the physical treatment of OPMD. Two of my colleagues, who are international expert on the disease, have joined me today to give you more information first on the surgical treatment of ptosis, eyelid ptosis, so Dr. François Codere, and the treatment of dysphagia, Dr. André Duranceau. So if we're going to review the OPMD, I think it's good to set the stage by saying we're going to discuss many different items, so you'll be able to follow as I explain more about OPMD. First, we're going to review OPMD as a kind of story by itself, then turn to the natural history, how the disease starts, how it progresses, talk a little bit about the end of life with this disease. Then a few words about our understanding or growing understanding of the pathophysiology, so therefore how does the disease appear at the cellular level, and then talk about the medical and physical treatments, and also a few words about future treatments. So OPMD, oculopharyngeal muscular dystrophy, was first in fact clearly described in a French-Canadian family living in New England in the States. The name of the disease was coined in 1962 in a very famous New England Journal paper by Victor and Adams, where they really gave the name to the disease to insist on the ocular, so the eye, the ptosis, and the pharyngeal involvement in this muscular dystrophy. They also showed that it was a muscular dystrophy. They also showed clearly, though that was already known, that it was a disease that was transmitted from one parent to not about exactly, if statistically to half the children, though that may change from family to family. Though the mode of transmission is usually one of transmission from a parent to half of their children, there are some rare cases where both parents may transmit a dominant mutation, which causes a rare, very severe form, but there's also parents who have essentially no symptoms but will transmit to their children a small mutation, and as long as the children get two mutations, they have a recessive form. So I'll review that a little bit later. So though it's variable, and that's one of the challenges of following those patients, the age of the beginning of the first symptoms, and particularly the eyelid drooping, is variable, but we talk usually in the late 40s, sometimes early 50s. Same thing to some extent for the dysphagia, late 40s, early 50s, though it can be a bit earlier, it can be a little bit later, depending on mutation and other factors that we don't know. And then there's about 10 years later, there is a proximal leg weakness, implying that people start having more difficulty, in particularly going upstairs, raising from the sitting position. And that's usually more late 50s, 60s, and it is extremely variable. But it's important to insist, because that's certainly what we've learned in the last few years, is that it's a really more universal phenomenon. It's just a question of age, when it will start. And it's more universal in the sense that it's a symptom that we certainly don't have treatment for. And therefore, even though you're going to hear extremely detailed description of really good treatments for the ptosis, the eyelid ptosis, and the dysphagia, for the general muscular dystrophy symptoms related to large muscle involved mostly in walking and going upstairs, there's no treatment for that. There's just no treatment. The variability, that is the difference between individuals in the same family, is huge. So people have the same mutation, and they may not start at the same age as their parent, their affected parent, or their siblings. So it's very hard in families for people to use a sibling, a parent, an uncle as a true image of what they will be at the same age. Some people have it more severe, some have it less severe. So it's important, particularly for people who are starting their disease and are worried about whether they will have the disease to the same extent as their parent or their sibling, it's almost impossible to predict. What we know is the earlier you start your symptoms, the more severe, the quicker it's going to progress, and the more symptoms you're going to have. But initially, essentially difficult, if not impossible, to predict how the disease will evolve in the affected. It was one of the disease where pathological marker, a very specific pathological marker, appeared in the 1980, was described by a French colleague and a Portuguese colleague, Fernando Tomé and Michel Fardot. Those very beautiful nuclear inclusions which you see here, and I suppose it's tippy. They give the idea that it's kind of like a tippy or a palisade. So it's a really tremendous ultrastructural findings, which helped for a long time diagnose patients before the genetic tests. So is OPMD common? The question is, we don't know for many populations. What we know that it's variable. So some population, like let's say northern the UK, we think it's about 1 in 100,000 people. In France, probably again 1 in 100,000 people. However, if you go mostly in the Spanish, Mexican speaking community of the southwest of USA, they think of more 1 in 15,000. In Quebec, where we're talking from, more 1 in 1,000 people. So there's approximately 6,000 Quebecers who live with the mutation. Not all have yet manifested the mutation. In fact, in the diagnostic facility, we have identified over the years almost 1,700 carriers of the common mutation. The highest prevalence is in a small population of Jewish people. Most of them are now living in Israel. It's the Bukhara Jews. But it's a very small community, maybe 30, 40, 60,000 people, and they have a higher prevalence for historical reasons. But it's not limited. It's really now we know OPMD is everywhere in the world. It's in every population. So you can be anywhere in Canada, in the States, or elsewhere, and though you may not have a clear family history, you may have OPMD. So it's not an ethnic disease. It's a universal disease. Complicated slide to essentially illustrate that now we know the cause. Most, if not 99% of the people have the same type of mutation in a gene, which now is called PAPPN1. In brief, easy to test, cheap test. We can identify if you have the mutation. If you have the mutation, you will develop the disease. As I said previously, we don't know when you're going to develop it, and we can't really predict how severe the disease will be for you. So it's an expansion disease. Here you can see it illustrated in black is the normal codons, and red and non-red and white is normal codons also, but of another nature. And this is a normal sequence in the gene. However, those are all mutations in the world. So you see there's many mutations. We even think now that some of them have appeared recently, some are very old, and they may be reappearing again. So whatever we do, humanity will always have OPMD as part of its living experience. So looking at patients in large cohorts in the world, we did a lot of work many years ago on the French Canadian, and we were able to show that variability. What we show here essentially is the age of the patient or participant, and that's a swallowing test. It's a test that grossly assesses swallowing difficulty. The more time it takes you to drink the 80 milliliters of cold water, the more your dysphagia is objective. And what you see is as we age, this is the line here, the time to swallow of patients with this mutation changes. That being said, you have people in their 70s who are still very close to what normal people swallow, at least the speed or the rapidity. And what we see also here is some people have a more severe dysphagia as quantified by this very simple test. And those people have a special genetic background. They usually have 2 mutations, either 2 mutations like this unfortunate Bukhara Jew, where he started a disease in his 20s and really in his 50s was like someone we see now more like in his 80 or more, very severe case. So variable, some of the cause for the variability is the genetic reality. That is, you can have 2 mutations, one from your mom, one from your dad. The rest, the size of the mutation may influence severity, but it's not as clear as we would like. And the rest are other factors influencing severity that still need to be identified. The common mutation is the mutation found in French Canadian in size, but we know that same mutation appeared many times in humanity. So the Bukharas have the same size of mutation, but it's not the same historical mutation. It appeared on other chromosomes. So yes, there's a common size or common sizes, and therefore the average experience of patients are about the same, but there's still people with very large mutation or smaller mutation that seem to have either a more not benign, but a more clement evolution or a more severe evolution. So we've developed simple criteria that are used now in studies and so forth. We try to make it the ptosis and the dysphagia objective. At the end, I think clinicians in the world now are very familiar overall with this condition. When they think of it, they ask for the test if no one in the family was tested. And it's pretty straightforward. They can get the results in a few weeks or months, depending of the availability of the test in the country they're ordering from. In Canada, it's very easy to get the results. And then you know you've got the disease, and therefore it explains a lot of symptoms. So if we go now to talk about the beginning, because some of you are maybe from families where the disease is known, but you don't know if you have it or not. This illustrates that in different size of mutation, the beginning is different. So in fact, if you look at here, the average age of onset as measured by many cases for the mutation common in Quebec, and in fact the most common in the world, is about 47 years old. So that's declared age of onset. That is, you say, I've started having my symptoms at 45, 48, 50. We sum them up, we divide them by the number, and it gives us that. But in fact, this is the reality. It's a spectrum. So some carriers will start having symptoms very clearly in the early 40s, and some will start having symptoms really in the late 50s. So it's a real big spectrum. So it's very hard for people with a family history to really know if they have it. What we've learned over time is if you think you may have it, it's probably, though you don't want to have it, it's probably better in those age group, if you have symptoms, to come forward, see your doctor. The neurologist or the geneticist or another professional can request a test, and then they tell you have it. It was part of your gift of life. No one to blame, obviously. Then it's more, I have it, I live with it. In fact, a lot of our family members learning in, let's say, at the age of 50, that in fact they have it, remove the kind of anxiety of maybe I have it, maybe I don't, and explain symptoms. And then they can learn from what we're presenting today and the progress of research that there's hope. There's hope for better treatment. You just have to be informed, see the right specialist, and then things can move and you can have a living with this disease that's better than other people who are not consulting the people who know about this condition. So the age of onset variable. The first symptoms, frequently it's just choking. Choking is common. Every human choke. Prolonged mealtime, very sensitive. You've been the person able to eat your sandwich faster than anyone else at work, and then suddenly you're the last to finish and you have a family history. It's suggestive. It's time to meet a specialist to have the test done. Avoidance of certain food, we've learned that from the families. Dry food, rice, things that stick. In fact, you're going to hear more about that later. The droopy eyelids are often asymmetrical at the beginning. You're going to hear a lot more about that. And at the beginning, you don't have weakness. So if you have an OPMD story, family story or history, and you have a lot of weakness in your legs, but you don't have swallowing difficulty or ptosis, your weakness is not related to your OPMD. You need to consult it. You cannot just accept it because it's not related. It would never come as the first symptom. So if you look at dysphagia on average, around 55, more than 50% of people who have the error will have manifested clear dysphagia, difficulty swallowing. Same thing for the ptosis, around 55, more than 50% of people, independently of the size of the mutation, will have manifested eyelid ptosis. This is to illustrate that, in fact, the weakness is a later phenomenon. I always say it's about 10 years later, and it's variable. You can be 65 and complain of no weakness, but in fact, when we test you, we observe some degree of weakness. Or you can be 65 and have a lot of weakness. Going upstairs is a problem, and that can all be part of the disease. And that's why you need to consult to be sure that it's part of the disease, that people, specialists, can agree that the weakness is proportional to the condition, or if there's something else, one has to react. So if you have weakness, it's part of the disease. Just consult to be sure that it's proportional. The weakness will progress, and so we see this is a complex image produced by the great specialist Jean-Pierre Bouchard, where you can see someone through time. Those are strength. The normal strength is 5, so those are all different muscle. And as you see the patient age, you see that you go from 5 here to 3, which are really poor strength, and in fact some muscle become 0. That means no movement. So over a period of about 9 years, someone can go from a pretty decent exam with some implication on his daily living to an exam that has tremendous implication, limited walking, often the use of a wheelchair. Again, it's not universal. Everyone has their own course. The average evolution is quite wide, so one has to keep that in mind. End of life. This is an image a little bit hard to understand, so I'll walk you through it. So essentially what we're seeing here are people with different 2 sizes of mutations. One is from the fantastic Uruguay population, and the red is from Quebec. And you can see that those are patients partaking in our study at that time, and you can see that there's a lot of living people in all the groups. So it's pretty much, in fact, a lot of people who are living, and then you start losing people. And you start losing people in their 70s, 75, 80. So more or less like what you would expect. So life expectancy has only been measured in one group, and it was found to be essentially normal. So despite you have this disease, despite maybe your mother, your dad who had the disease died early, most people will live a full life in terms of age. However, as you age with this disease, the condition has greater and growing impact. That being said, you'll hear about very good treatments for some of the symptoms. So we can make a big impact on your living with this disease as you age. Some we can't, and particularly the weakness, and then we have to use other means to help you get around. And therefore, yes, you will live long, but you will have more difficulty swallowing if you're not treated. You will need surgery for your eyes, and the walking will do our best to help you. But at this point, at least on the market at this point, there's no good treatment for the walking. And yes, people will develop at the end of life more pneumonias, and they can be quite severe. And sometimes it's the cause of death, but my impression is that most of the people die of unrelated disease, though they can have, let's say, a heart attack in the context of a huge pneumonia. But at 82, that's not unusual. So, yes, quality of life drops, but life expectancy probably stays the same. So, I didn't want to dwell too much on understanding the disease. The gene was published in 1998. We have the privilege, I and Guy Rouleau, to find the gene at that time, showed that it was a universal cause in all populations. Since then, a lot of work has been put in to try to understand. It's a very difficult protein to work with because it's a protein that's essential, binds to all the mRNA. And what we showed first is that, in fact, the wonderful palissade I showed earlier, the Fernando Tomé Fardeau inclusions, are, in fact, the protein that has aggregated. You can see it here. The OPMD inclusions are full of the abnormal protein, but they're also full of a lot of other stuff, junk, a lot of RNA. So those inclusions, which are the marker, are clearly showing that the cell is trying to deal with a bad protein. And that bad protein essentially produces those huge inclusions. What we still don't know is whether those inclusions are protective or in fact leading to the disease. We still don't know all those years after. So it changes from one year to another what you favor. I think most people at this point feel that the abnormal protein causes a problem when it's trying to work alone and with partners rather than when it's in the inclusion. And therefore, if we can find a way to have the normal protein that's not floating around but doing its job in the nuclei in a way that it cannot aggregate and it can still do its work properly, then you can correct the problem and then change the evolution of the disease. So in brief, we still don't know completely how it works, but we know that if we can find a way to either replace the bad protein or a way to get the protein to be an environment where it does a better work, we could reverse the disease and potentially change the evolution of all of the patients with this. This is an image that I like. It's an image to just illustrate that in fact the protein aggregates in filaments. So it has, that protein is a sticky one. And that's why any environment that would make it less sticky can change something. And I will return to that as we go and talk about treatments. So again, still no treatment, at least no prescribable treatment for the limb girdle weakness, that it is the skeletal muscle weakness. So what can we do? What can we do? We've learned a lot of things. My colleagues will review some of those. We recommend people, like, for example, to use mouthwash more to kind of make their saliva clearer. We tend, for example, we've learned that a lot of those patients are very sensitive and respond poorly to some of the anti-cholesterol drugs like statins. That tends to worsen their dystrophy, so we shy away from those drugs if we don't have to do it. It's important, as you discuss with your doctor, why am I taking this drug for my cholesterol? He will insist on the risk factor, the cardiovascular risk factor, but you have to bring forward, look, there is evidence that in fact it may help induce my dystrophy to progress faster. So it's a debate. At the end, there's no one answer. It's an answer related to your health and the discussion of risk factors for your cardiovascular disease. But it's still something that's very important, but because unfortunately over the years I've seen many of those patients who've had this problem, and in fact it's partly reversible. So we have patients on those drugs that we stop and they do better after, they recover function. So keep that in mind. Pain management, until recently, we always thought that it was a painless dystrophy, or people had pain because of the way they walked, their age, other factors. But in fact, we're realizing that there is a subfraction. We don't know the exact number, but not a negligible number of patients, usually who have a more severe dystrophy, that will develop pain syndromes. And they need drugs for that. They need management. We even have a few in Quebec that go all the way to pain clinic. So I'm not saying OPMD is painful. Most people till their 80s have no pain related to the dystrophy. But if you have pain with OPMD, you cannot exclude that there's a relationship. So that's important as you discuss that issue with your treating physicians. In bed, head elevation, all the electric beds that we prescribe in Quebec for those patients. We've developed even a cane, which has a step in it to help going up. So those are minor things, but may make a big difference depending on your work setting or how you like to be independent and you're walking in all settings. We use a lot of walking sticks to help people return to swimming. For example, they go in the ocean, they put the walking sticks in the ocean floor, and then they swim and they come out of the ocean using those. In Quebec, where we like to hunt, fish, people go back to those activities because they can bring their stuff, and even though the land may be going up and down, they can still practice their sport and be outdoors. So there's ways to make your daily living easier and to ensure that you can do the things you want to do as late as you can in your life, but they're mechanical helps, but they cannot be neglected. And then obviously a small percentage, and I have to insist on that, it's a small percentage. So in the less than 5 or 10% in the 70s, that will need some kind of wheelchair scooter. So though it's a small percentage, it's important to uncover who needs them. So in fact, if your walking is deteriorating and you could benefit from this type of help, please do. For the ones who are at the beginning of the disease, don't think you will lose your walking. Even the people who are using wheelchairs and scooters can still walk. So they haven't lost their walking. It's just walking long distances, walking uphill. Very few have ever lost walking with this disease, at home at least. So what are the future treatments? At this point, international groups, particularly the European group, collaborative group, have looked at a lot of drugs. In fact, all the Food and Drug Administration approved drugs on different models of the disease. And unfortunately, that effort has led to a lot of results, but none of them have now panned out to all the way to do clinical trials in humans. However, there's one drug, Trehalose, here, which is in development as a drug by BioBlast Pharma, has been started as a trial, and it was the first drug that showed really remarkable improvement in a mice model of the disease. So now the drug is in trial, and a new trial will be starting shortly in 2017. This is a drug that changes the intracellular environment, and we think it allows the protein, as I said earlier, to have a shape that allows it to, despite having the abnormal stickiness, is allowed to do its work better. And in fact, we hope that will lead not only to improvement of key symptoms like the ptosis and the dysphagia, but also the walking, the skeletal impact. There are other cell therapy-based treatment, mostly developed in France. There's also a large collaboration trying to find a way to get rid of the bad protein and have only good protein around by doing different types of strategies. So for people who are listening to this recording, we are, and many of us in the world are working to find a solution to this disease. We've learned a lot over the last 20 years, but we still have a lot to learn. Treatments are better than ever. You'll hear about the surgical treatments in the next minute or two, but the medical treatments will continue to improve, and stay hopeful, and we don't forget you. Thank you.
It's with great pleasure that I'm here with you today to discuss the eyelid portion of oculopharyngeal muscular dystrophy. And I want to thank Dr. Brais for inviting me. And I think that it's important that you get all the aspects of it, and regrouping the different physicians that are involved with this disease, I think, is important so that we can treat it well. Oculopharyngeal muscular dystrophy, as far as we're concerned, is one of the diseases, and certainly in Quebec the most frequent by far, that can give ptosis. But there are also other diseases that can give it, and that can give the droopy eyelid, and we'll discuss them very quickly at the end so that they're not confused together. This story starts obviously a long time ago when the three sisters crossed the Atlantic to come and help create the world, and the new world. And I think that it's very important that we acknowledge the contribution of this group, and they've basically followed the history of French Canadian in Quebec and in North America. It is the result of a faulty gene, as has been discussed by Dr. Brais, and what it does in the eyelids is the accumulation of the protein eventually will kill the cells of the lid muscle. Why that muscle is more sensitive than others is difficult to understand, but basically it loses its function over time and becomes replaced by fat. And we can see here the aponeurotic, or the non-muscular portion of the muscle, and the muscle itself, which is deeper in the orbit, is replaced from muscle fibers or more reddish tissue to become fat. As has been said, the onset is in the early 50s, but there is a wide variation on the ptosis or droopiness of the lids. And we have a small subgroup of patients, as seen here, that will develop it a little bit later on. And there are some patients that will get it earlier. And as Dr. Brais has discussed, it is in some cases difficult to understand, but some of them have a genetic reason for it, having other genes that modulate the main gene to make it worse. Typically, it's a slow progression with a mild to moderate ptosis in the first few years and a good amplitude of movement of the lid early on. And the classical approach was to say, well, if the elastic is not as strong, maybe we could shorten it and make it more efficient. And that was the classical approach, is to do a resection of the levator muscle. But contrary to what we find in congenital ptosis in children, to be able to elevate the lid with that weak muscle, often a large resection of the muscle was necessary. And because it's an evolving disease, especially in people who had more severe involvement or early involvement, the recurrence was high because the muscle continues to weaken. It gave good result, and this was done in many patients. We see here 62 years old, a little bit later onset, but already she had a severe ptosis and moderate levator action, and she refused to have something else done, and we did a levator resection. And initially, she certainly will have a good result, as seen here in the about a few weeks later, and she did well for many years, but you can expect, if her, as Dr. Brais was mentioning, the life expectancy is normal, that probably around the age of 68, 70, 75 years old, she's going to need something else to be done for the lids to stay at a proper level. These are other examples where levator resection was done. And very often people thought that if you do a levator resection, you have less problem in closing the eyes, but that's not always the truth. This gave a very good result in primary position, but you can see that the lids don't go down too well when the patient is looking down. This is another example with levator resection doing well, and in some of those patients, when we were doing those, we were also removing a fair amount of skin at the time of surgery. And in some of them, the result were semi-permanent, giving them the ability, with the shortening of the skin, to open their eyes with their brow. This is another example of a patient first seen in his 50s. And we did a levator resection, did well, but came back and did well initially, but came back a few years later with a much more severe disease, and he needed to have something else done, and this was done by doing what we will discuss later, a frontalis suspension, as done here. This is at the time of recurrence. He was as bad as the first time around. In fact, I don't have the picture of it, so I took, but he was basically back to normal and had the levator, the frontalis suspension. So surgical options are dependent on the age progression, and certainly if we have somebody who has a late onset disease with good levator action, we can offer still a levator resection, but don't do that too often. We want to look at how the eyes are shaped, and when we do frontalis suspension, as we will discuss, some shape of the eye are a little bit less optimal for a frontalis suspension, especially when the eyes are deep set compared to full lids. But often many of you will tell us what you want to do, depending a little bit on your experience. But certainly, the clinical observation that when we have early onset, we have sometimes somewhat of a more rapid progression, lead to high recurrence in those patients when we work on the muscle. And it's only on the late onset patient with very slow, very mild progression that we will offer levator resection. So frontalis suspension has become our first choice, and this is what we will discuss. Many of your parents, or if you're older, have had a frontalis suspension that was done by using your own tissue that we used to harvest in the leg. And there were different type of patterns to suspend the eyelid, but basically the principle is the same. It's to use the frontalis muscle that is still good and gets involved only very late in the disease as the new motor for the eyelid, and basically put a pair of suspenders inside your lid so that when you lift your brow, you lift the lid. And we've modified that through the years, and this is how it was done. Could be done either by opening the lid or by just passing the strings. And it gave very satisfactory result with certainly a more permanent improvement. And we can see here in this gentleman, this is a patient that underwent a frontalis suspension, and we can expect that it's going to be good for life. The lid had to be put relatively low so that the patient is able to close the lid with the brow movement, as seen here in an early post-op again, when we were doing mainly fascia. Unfortunately, some patient with the fascia had a syndrome that is not well described, but underwent. This is a patient that had been operated, was doing well for a number of years, but these patients, some of them, for unknown reason, underwent a contracture or scarring of their bands, and we see him here about 6 or 7 years later, and very slowly his lid have become almost stuck to the roof of the orbit, and these were very difficult to take down. So this is a patient that had that surgery where we had to cut down the scar tissue and put the lids back at a more proper level, often with the shapes of the lid that were not always optimal. Also in the legs, sometimes we had the patient having a pain in their legs or prolapse of the muscle when the fascia was harvested. This usually was not a big problem, but certainly we had to do the surgery under general anesthesia to do it, and the recovery with the two sides being involved was longer. And we had always that question of having that contracture of the muscle, of the bands. On the other hand, in patients that did well, the number of reoperation with that type of surgery was much lower. I'm sorry. Okay. So I'm showing here the different type of eyes, and you can see here that if we put strings, they're going to show a little bit more when the eyes are deep set, and the direction of the pull being fascia or strings is going to be more, instead of going straight up, will go a little bit forward before it goes up. So in some patients, the frontalis suspension gives some problem by having the lid becoming detached from the eye. In the last, I would say the last 7-8 years, or maybe even more, we've switched from the fascia, for all the reason I've given, to artificial material. And now our choice of material is a proline suture, or they're nylon suture that are used to do it. And they're basically just passed in the lid. And this can be done, as you see here, the patient is not asleep, so this can be done under local anesthesia. The patient doesn't have to stay in the hospital and can be out a few hours later. At the beginning, we were doing a more complex pattern using two strings that were intertwined together to give a good contour, and this is seen here, and those sutures were attached in the brow so that the suspender was fixed. Different type of material have been used by different surgeons. Myself, I've become very familiar with the proline, and this is certainly our choice number one now. The silicone bands that some are using tend to cheese wire a little bit more and are more fragile over a long run. And some people are using Gore-Tex material that is porous, but if it becomes infected, it's very difficult to remove. The advantage of the suture material is that they're permanent, but and there's only one side that needs to be operated on. Because they don't scar down in the tissue, if there is any retouch to do, is much easier. It can be done under local anesthesia, and we don't have that scarring or contracture that we've seen in some patient with fascia. On the other hand, over time, there's a number of them that will need to be redone because they can slip with time. If there's any trauma, they can break. But if they're removed from the lid is basically as it was before without much changes. Again, as I was saying, we had a pattern where we were putting multiple sutures, but we've shifted to a more simple system now where we just pass one string through the lid and it's attached in the medial portion. And although it looks simpler, the results are as good. And we did a review of this and compared both techniques between 2006 and 2011. And basically, the result, we start with a population with changes that were pretty similar and ended up with a palpebral fissure, meaning the distance between the lower lid and the upper lid being pretty much the same with one pattern or the other. The big advantage here is that if the suture has to be retouched, there's only one nut that has to be found, and we leave long strings that can be undone and tightened. This is an example of a patient with this pattern. He's seen here a year and a half after his surgery, and although the pattern is simpler, the contour is very comparable to what we were able to get in others. This is another example early on, and you can see that when this is passed in the lid, it creates very little damage, and the patient go back to their activity quite quickly without much swelling. This is another example. We see here that if the brows are moving well, we're going to have good movement of the lid, and it gives quite a natural look when they look up. We tend to try to pass the suture in a way that it will form a natural crease. In down gaze, there's always a little bit of lack of movement going down, despite the fact that the patient is putting his brow down. But in general, most of them will close quite well. There are a few changes on the forehead. You can see here the little dimple created by the passage of the bands. and here in this case a little asymmetry of the fold, but all in all, very good result. Sometimes it has to be retouched. This is a lady that allowed me to use her full picture that I saw a few weeks ago, and you can see here she's been overcorrected here. If she had fascia, she would be much more difficult to revise, but we can go back and just reopen here, find the knot, and undo it a little bit. This is another lady I crossed in the cafeteria last week, and she acknowledged me and said, "Oh, how are you, doctor?" And it has been done about 5 years ago, again with the box pattern, and you can see that in many of these the result will give a good correction over quite a long time. Another example of the same thing in a younger patient, and he's been he's had his frontalis suspension about 3 years ago. Post-op, what are the problems that we can have? You can have a little bit of lack of closure, especially in the first week, and ointment will have to be put in the eyes every 2 or 3 hours. Sometimes eye irritation result from that. But if the lids are too low, we can always go back quite quickly. But in general, it gives a good improvement. These surgery now, for many years we were very few to be able to do that. But these surgery now can be done in all the main center in Quebec, or you can be referred if necessary. In Montreal now there are 6 or 7 people that are doing those different surgery, and as you can see, there are oculoplastic surgeons in many areas. There are the different other disease that exist. There is the myotonic dystrophy, and this should not be confused with CPO, as it can give a much more severe disease, and the eye movement are also involved. It gives cataracts that are typical to that disease, and you can see here that in this condition the variability can be much worse than in what we see in CPOs. Finally, the last one that we see that is also part of those is called mitochondrial disease. And in these, the ptosis tend to be much more severe early on than what we see in oculopharyngeal dystrophy. And the eyes are not moving well, so surgically they're much more difficult to correct than oculopharyngeal dystrophy. So I'm just putting in perspective that although oculopharyngeal dystrophy is a disease that has drawbacks on the long run, we're comparing to other diseases, we have good ways of correcting it. I'm just going to skip those two. Basically, I want to finish and offering the hope that at least for the ptosis in OPMD, although we cannot correct the underlying condition, it can be corrected surgically. Thank you.
Good afternoon. My task today is to discuss the difficulty in swallowing aspect of oculopharyngeal muscular dystrophy, and I will try to explain that aspect to you in the following presentation. Most of patients presenting with oropharyngeal dysphagia have a difficulty that is usually related to the cricopharyngeus muscle that you see right here. That cricopharyngeus muscle is very small, very tiny, and when we look at the pressure profile of that muscle, you see in green that it actually occupies only a small part of what is the increased pressure seen at the pharyngoesophageal junction. The approach that we use in patients with oculopharyngeal muscular dystrophy is described here. This is an operation that has been described initially by Professor Montgomery from the Mass Eye and Ear in Boston, and it's the operation he used in patients of French-Canadian origin that had migrated to the New England area. What we do during that operation is we initially transect 2 centimeters of the cervical esophagus muscle, and as you've seen on the recorded pressures during the operation, no pressure change can be observed. If, however, when we transect the cricopharyngeus muscle, you can see that there is quite a significant decrease in resting pressure in the sphincter resulting from that part of the operation. But when we prolong the transection of the muscle on the hypopharynx, the transection of the hypopharyngeal muscle results in further significant decreases in resting pressure at the pharyngoesophageal junction. And when we look at patients overall with the resting pressure, showing that no change occurs in the cervical esophagus transection, significant changes occur transecting the cricopharyngeus, and even more decrease in pressure are seen when the hypopharynx is transected. And when in the awake patient after the operation, the resting pressure in the sphincter after the operation shows about a 66% decrease in pressure, and in our perception, this probably results in a significant decrease in resistance to transit of the swallowed bolus from the mouth to the cervical esophagus. This summarizes the experience. That slide was published a number of years back, and I would say that we probably have more than double the numbers that you see here. We are concerned here with the myogenic aspect of the disease of oropharyngeal dysphagia, but the same difficulty in swallowing can be seen in patients with pure neurologic disease, with idiopathic dysfunction of the sphincter, either with or without a diverticulum, and even after operations. So what we will discuss from now on is strictly patients with oculopharyngeal muscular dystrophy, and this is shown on this cartoon here that was published a number of years back in a local journal in La Brais, showing Zachary Cloutier on the left with his spouse, Sainte Dupont, who are at the origin of 12 generations of transmittal of the disease in the French-Canadian population, mostly in Quebec. This is a direct descendant of Zachary Cloutier. His name is Cloutier as well, and this patient was followed for 14 years before having his operations on the upper sphincter. This slide that you recognize from Dr. Brais' contribution shows that Quebec on your left is where we see the highest concentration of oculopharyngeal muscular dystrophy in the whole world. But as you see, this is a disease that is seen all over and well documented at present. The way we investigate and try to quantify actually the disease are going to be shown in the following slides. The first meeting is usually a clinical meeting where on your left we try to assess the difficulty in swallowing by quantifying in a number, with a number, the severity, by recording the frequency, the duration, and the severity of the symptom. And this is shown on the left in the preoperative position, and we try to follow this table in every patient that are seen now. In the postoperative, we do the same assessment, but we also follow with a quality of life assessment to try to quantify also the improvement in quality that these patients can report. This is the initial report that was published in 1978, showing the severity of each symptom: the dysphagia to solid, the dysphagia to liquids, the incarceration of foodstuff when swallowing, the regurgitation by the mouth and the regurgitation by the nose. And all those symptoms were improved quite significantly after the cricopharyngeal myotomy. The tracheobronchial symptoms are summarized here. They are quite significant, as you all know. Aspiration during meals, aspiration during nighttime, coughing when swallowing, and the presence of bronchorrhea during nighttime are also quite significantly improved by the operation. Radiologically, video radiology recording is probably the most accurate in documenting the anatomical change that are seen in oculopharyngeal muscular dystrophy. On your left, you have the imprint of the upper esophageal sphincter with a trace of tracheal aspiration right in front of the esophagus. And on your right, you have stasis in the hypopharynx in the upper part of the slide with clear aspiration in the trachea when the patient swallows. We try, in addition to visualization of the abnormal anatomy, we try to quantitate the emptying capacity of the pharynx with a radionuclide bolus. In the upper part of the slide, you see a normal swallowing curve where the bolus, with the radionuclide bolus, which is water in this situation, shows that within 3 seconds, the hypopharynx is usually empty of the bolus itself. When you look at dystrophy in the lower part of the slide, you see that the maximal activity is much slower in flowing into the esophagus and in the emptying of the hypopharynx, with quite a significant retention at 3 seconds. This is shown this is one of the radionuclide slide. Radionuclide showing initially in the mouth, and every 2 seconds the recording shows that there is quite a significant retention in the hypopharynx. This is after the operation, and you see that there is still a bit of activity remaining in the hypopharynx, and this is probably due to dilatation of the piriform sinuses and valleculae. During the radionuclide study that we used to quantitate this function, as is shown here, and in our initial assessment, we were using strictly water, and we could document a significant improvement in emptying only in the supine position. And it is only after becoming conscious that, and this is from the work of Dr. Périclavé in Spain, you see that on the left, there's no difference in the significant recording between normals and dystrophy patients when water is used by itself. But the more we offer a thickened bolus, like with a viscosity of nectar or the viscosity of honey, then the diagnosis becomes more evident by the retention of the various viscosity boluses in the hypopharynx. Functionally speaking, this is a manometric tracing as we used to do it early. This is a perfused manometric tracing showing the very rapid contraction of the pharynx in the normal on your left. And you see the type of poor contraction, poor repetitive contraction that is seen in dystrophy patients on the right. And the repetitive activity, usually patients with dystrophy will show repetitive efforts at trying to push the bolus through the upper sphincter compared to the normal population where a single contraction is usually sufficient to empty the pharynx. The sphincter itself, you see on the left that in the preoperative position, the repetitive efforts at swallowing and a sphincter which relaxes quite normally, but with a wider relaxation time. On the right, the pressure is decreased, and the resting pressure is also significantly decreased. And after the operation, the functional results are shown here, with a significantly decreased resting pressure and a decreased closing pressure of the pharynx, probably resulting in less resistance to bolus transport in the esophagus. The relaxation time in the pharynx is decreased significantly as well. This is the second study that we've published with Don Castell, a American gastroenterologist who came to our laboratory and where we recorded the function of pharynx and upper esophagus with intraluminal sensors. And this was published in Dysphagia, 1995, and this is probably the most accurate recording of function. And what we have shown there is that when there is less severity in symptoms, pressure is better, and the manometry is better as well. The more the symptom becomes severe, the slower the opening time becomes, and correlates with the severity of the symptoms. For the same reason, the upper sphincter shows manometrically a mild change when there are few symptoms, but the more progressive the disease becomes with more severe symptoms, the opening abnormalities become more evident. This is actually changing, and this is one of the more recent recording that we are actually doing. We are now using high-resolution manometry with a sleeve recording of the pharyngoesophageal junction, sensors in place giving actually 96 point of recording of the pressure in both the pharynx and the upper esophagus, where this is the equivalent of an electronic swallowing curve. The upper part of the slide shows the imprint of the upper esophageal sphincter. You can see the proximal esophagus and the contractile integral pressure as shown in the recording in the esophageal bolus, and lower down you can have an idea of how the lower esophagus, the lower esophageal sphincter behaves when the patients are swallowing. When we study in dystrophy patients, that allows us to measure directly the pressurization during the pharyngeal contraction. We have a direct measure of velopharyngeal muscle, hypopharyngeal muscle, and upper sphincter muscle during every swallows. We have the exact behavior of the upper esophageal sphincter measured simultaneously, and also it gives us the capacity to record the integral pressure of the cervical esophageal pressure, which is also striated muscle at that time. And during this assessment with a computerized measurement of the swallowing behavior, this gives us also the possibility of measuring the intrabolus pressure, summarized in A, B, and C, meaning the pressure in what is swallowed when the sphincter is open. And this is a very important index that has been well documented in the literature, a very important index of the resistance and obstruction to the swallowed bolus. And so those represent the new and more recent way of recording function in the normal and in the dystrophy patients. What those observations brought us to do today are a new assessment and new validation of what oropharyngeal dysphagia causes in dystrophy patients. And we're trying now to validate the clinical questionnaires with the swallowing impact on quality of life, the Sydney questionnaire, and the gravity, the severity of the symptom as described in our table. We are trying to validate the functional evaluation in the nuclear scintigram, the high-resolution manometry, and as well as the video fluoroscopy. And we are trying to document with this type of investigation with the same validation in normal patients and in oculopharyngeal muscular dystrophy patients. I thank you for your attention, and we're ready for your questions. Thank you.